Welcome to PCR TV, PCR Paris 2018. My name is Joachim Schofer. I'm an interventional cardiologist in Hamburg. And next to me is Nicola Piazza from Montreal. We would like to talk on the significance and importance of tricuspid regurgitation. So, Nico, my first question is, why is this named the forgotten valve?
Joachim, thank you. It probably extends, and it's a cultural thing. It comes back probably from a publication in 1968, where Nina Braunwald published a series of patients undergoing surgical mitral valve replacement who had concomitant tricuspid regurge. And they noticed that after that operation, that pulmonary pressures went down, and that in some patients, the tricuspid regurgitation improved. And so that set the stage really for physicians to perhaps not treat the tricuspid valve while patients are going for mitral valve surgery, and perhaps with time it became forgotten.
So what is the reason for tricuspid regurgitation?
Yeah, really, we have two types of tricuspid regurgitation like we have for mitral regurgitation. There's primary and secondary. Primary means when you have something intrinsic, an intrinsic abnormality of the valve leaflets, and secondary, something wrong with the ventricle. 90% of patients have functional tricuspid regurgitation, and 10% have primary tricuspid regurgitation. So really in clinical practice, what we encounter most often every day are those patients with functional TR.
Okay. How common is this?
You know, there was a Framingham heart study that found that approximately 1.5% of males and 5.6% of females have moderate to severe tricuspid regurgitation above the age of 60. And this was an all-comers, of course. And so tricuspid regurgitation is also more common in females than in males.
Okay. Are they a specific subgroup of patients with a higher incidence or prevalence of TR?
You know, it's interesting that when we see our patients undergoing transcatheter aortic valve replacement or undergoing MitraClip implantation, and in both scenarios, whether it's for the aortic or mitral transcatheter procedure, approximately 1 out of 3 patients has moderate to severe TR.
So this is quite a huge number.
It is.
Does it impact the prognosis of those patients?
So if you just look at patients with secondary tricuspid regurgitation, whether or not they have RV dysfunction, pulmonary hypertension, as you develop more and more tricuspid regurgitation, it severely impacts mortality. Just to give you a number, at 5 years, those patients with severe TR have about a 40 to 50% mortality. So 1 out of 2 patients with severe functional TR left untreated will die.
What about patients who undergo a TAVI or a MitraClip and have a concomitant TR? What about those patients?
We found similar findings in those patients, even after adjustment for baseline characteristics. Severe MR, like severe TR, is a prognostic indicator for increased mortality long term. So the idea comes, should we be treating the severe TR in patients undergoing transcatheter aortic valve replacement or transcatheter mitral valve interventions? And so this becomes another addressable population.
Okay. And what about the pacemaker patients?
That's an excellent question, Joachim, and I hope you were going to ask this question. There was a study not too long ago published by Jerome Bax and his group in the Netherlands, and they found that approximately 40% of patients have significant TR long-term after pacemaker, and in those patients the mortality was higher. So yes, and that's another addressable population. Patients who come to the clinic with a pacemaker and have moderate to severe TR, do we have the necessary tools to repair it?
That's very interesting. So what do the guidelines say about the treatment of TR?
There's not very much about how to treat TR in the guidelines, and that's because we don't have much evidence. The surgical evidence supporting what they do is very poor. If you want to look for a class 1 recommendation, the only class 1 recommendation is if you have a patient with left-sided disease undergoing surgery and they have severe secondary TR, that's a class 1 recommendation to have a combined surgical procedure, including the tricuspid valve. There's also, believe it or not, an indication to repair or replace the tricuspid valve if you have mild or moderate TR. And in those cases, the surgeon has to look for the annular dilatation. So if you have an annular dilatation greater than 40, or your indexed diameter is greater than 21 millimeters per meter squared, even in the presence of mild and moderate TR, those patients may have an indication for surgical intervention.
Yeah, and we know from the literature that this does not increase the risk, the surgical risk, if the tricuspid is approached in the same session.
Correct. You know, that's a myth. The myth is that if you send a patient for mitral valve surgery and you include the tricuspid valve, that you're going to increase the mortality. The acute mortality is the same, as you suggest. Correct.
So this is very contrast to the results we have from redo procedures. What is the risk of a redo procedure? If the patient is coming back with severe TR after mitral or aortic intervention, what's the surgical risk of those patients?
Yeah, you know, Joachim, we should think twice before sending a patient for a redo tricuspid intervention. So if you look at the recurrence rate of TR after surgery, it's approximately 30% at 6 to 12 months. And if you do send your patient back for a redo surgery, the mortality can climb up to 20 to 35%. And that's consistent across several studies. So doing a redo tricuspid intervention, surgical intervention, is not a good thing.
So what do you think is the place for future treatment options, for percutaneous treatment options?
Right. You know, based on our discussion, it appears that the stage is set. We're dealing with a valve that it has a tricuspid regurgitation is highly prevalent. You have a valve that is rarely treated in isolation surgically. The mortality rates for a tricuspid valve surgery hover between 5 and 10%. You then have a very high risk for redo surgery. You have poorly evidenced guidelines with all of this. And now perhaps you have a percutaneous procedure. It's a venous procedure that is extremely low risk, that perhaps is associated with a great safety profile. I think we need to improve the current effectiveness of our devices, but the safety profiles is very good. And there's a potential for reintervention or perhaps combining techniques. So I think interventional cardiologists should be excited about the field. I think when you look at the characteristics of the aortic, mitral, and tricuspid, I think the tricuspid valve has perhaps all of the characteristics we want to implement a percutaneous transcatheter procedure.
Very interesting. Thank you very much, Nico, for this very interesting interview.
Thank you.